So I'd like to begin with Professor Julie Considine. She's Professor of Nursing at Deakin University. She's going to be talking about improving outcomes from in-hospital cardiac arrests. Thanks, Julie.
Thanks, Alex, and thanks to the organisers for the opportunity to speak today. The program looks amazing and as always they've done a sensational job, so thanks very much. How do I get down to my... Okay, so I was tasked with looking at how can we improve outcomes from in-hospital cardiac arrests. In terms of my disclosures, nobody's paying me any great amounts of money to do anything in particular, but I'm open to offers, so let me know later. But I guess my interest is I'm the College of Emergency Nursing Australasia representative on the Australian Resuscitation Council, and I represent Australia and New Zealand on the International Liaison Committee for Resuscitation, so this is stuff that I'm clearly interested in. So I think when you look at data from in-hospital cardiac arrest, and I'm from Melbourne and I'm really pleased to say I think we have one of the best ambulance services in the world here in Victoria. And what they've done in the out-of-hospital cardiac arrest space is quite extraordinary, and obviously Seattle is the panacea, but our cardiac arrest outcomes are getting better and better. And look, it does take a system to save a life, but they've really pushed initiatives like bystander involvement, post-cardiac arrest care. There's a lot of conversations internationally going on at the moment about cardiac arrest centres, so a bit like trauma centres, I guess. But I think our out-of-hospital colleagues have really set quite a high benchmark in terms of how do we improve outcomes for these patients. I will say though that the out-of-hospital cardiac arrest patient population is different to the in-hospital cardiac arrest population, but that doesn't mean that we can't aspire to some of the same outcomes that they're achieving in the out-of-hospital space. I finished my talk a whole week early. I was really pleased with myself. I'd sent it to Amanda, and then a paper happened to be published by Professor Jones, and I thought, bloody hell, now I have to rewrite my talk. So what I was going to say was we actually don't know, we still don't know very much about the in-hospital cardiac arrest space in Australia. So Jared Fennessy wrote a beautiful systematic review in 2016 about the epidemiology of in-hospital cardiac arrest, and that was of 30 different studies. And then Darryl and his group published a paper in the last couple of weeks also looking at in-hospital cardiac arrest. So we know that it's an infrequent but obvious event. It's not a great surprise that the age range of these patients is in their 60s and 70s, which for those of us working in adult hospital is the bulk of our patient group. And about 2/3 of them are men, so I'm not even going to comment on that. We know that the incidence of cardiac arrest is sitting around, in Jared's systematic review it was 4,000 odd cardiac arrests in over 1.1 million hospital admissions. In Darryl's group there was 152 in-hospital cardiac arrests in over 180,000 hospital admissions. 2/3 of them are witnessed. Monitored cardiac arrests, there's a bit of variation in the literature, but again, not uncommon events. And in terms of initial shockable rhythms, in Jared's work they looked at VF particularly, it was about 1/3 of patients, and in Darryl's group they looked at shockable rhythms across the board, and again it was around 1/3 of patients. So that's the sort of profile of your in-hospital cardiac arrest patient. What these two studies have highlighted though is that our documentation of in-hospital cardiac arrest and of the details of resuscitation is actually quite poor. So we kind of know that the median time to CPR is quite quick. We know that the median time to defibrillation is not too bad, and I think that's probably become better since we've put AEDs in all of our clinical areas, and you don't have to wait for the code team to bring the defibrillator. We know that median time to adrenaline is less than 5 minutes, and to ROSC is about 10 minutes. In Darryl's work, they looked at the frequency of interventions, so about 1/3 of patients were defibrillated, which matches the 1/3 of patients that had a shockable initial rhythm. Lots of people are getting adrenaline and a little few are getting amiodarone. So in terms of outcomes, we know that there was always an old adage, wasn't there, that about a half of patients survived their initial event and about half of them went home in various states of neurological capacity. So in Gerard's work, about half of patients are getting ROSC, but I think Daryl's work's shown that we're actually getting better at getting patients through that initial arrest event. So nearly 70% ROSC is actually pretty good. Need to know where your hospitals are that you did your study. In terms of in-hospital deaths, about 3/4 of these patients won't go home. But if you do go home, there's reasonable 1-year survival, and in terms of longer term survival, we're still not really sure because there's been a lack of studies following that up, but I believe Daryl's group are onto that. If you look at the out-of-hospital cardiac arrest data that's coming out of Ambulance Victoria, there's pretty good evidence that people's quality of life post their arrest is reasonably good. So I think the outcomes for these patients, if they survive the event and go home from hospital, is looking quite promising and probably more promising than it's looked for a long time. When we look at the longer term outcomes, we know that when people go home, the functional status, which is measured by CPC, which is Cerebral Performance Score, it's a pretty blunt instrument, I guess, in terms of it tells you about someone's sort of functional cognitive status, but it doesn't really say whether they went home, leading a life that's fulfilling for them. Is their quality of life good? Are they back to doing the activities that they like to do, or are they just really miserable even though they've survived their event? So I think there's a lot of work to be done in that follow-up space that we're really not across at the moment. So it really does take a system to save a life, and if you look at the out-of-hospital cardiac arrest, we've had the chain of survival for many years. If you look at in-hospital cardiac arrest though, there's a whole lot of people that need to do their job and do their job well in order for that patient to have a good outcome. And so I think the first thing we can do to improve survival from in-hospital cardiac arrest is to stop it from happening in the first place. That's the number one big ticket item really. And so that's all of the stuff that we heard about this morning, good surveillance, and I'm a nurse, so I think nurses play an absolutely fundamental role in this space. Interpretation of clinical data, data-driven decision making, and appropriate goals of care for some patient groups. The other thing I feel quite strongly about is if we're going to do CPR, it needs to be on the right people, and we need to do it properly. So we need early and effective chest compressions, early defibrillation, avoid overventilation, minimal interruptions, and early defibrillation with a minimisation of pre and post-shock pauses. The other thing that I'm very clear about is that resuscitation doesn't stop once you've got ROSC. In fact, the fun's just starting really. And evidence-based post-resuscitation care is getting a lot more airplay internationally, and I think we're starting to understand more and more that once we get ROSC, if we don't do our job in the post-resuscitation space, that patient will have a poor outcome. And I think it's nurses that are really primarily responsible for operationalising the targeted temperature management and the glycaemic control and making sure that the ventilation's appropriate. That's what we do here. Making sure that your inotropic support is appropriate. So we have a really important role to play in that space. And post-resuscitation care should start wherever the patient is resuscitated. So it shouldn't matter whether they're in the ED, the cath lab, the ICU, the ward. Okay, they should get the same care. We need to prevent post-arrest syndromes, and so Jerry Nolan's internationally been a real leader in this space, and so we need to prevent things like brain injury from targeted temperature management and good blood pressure control. We want to prevent myocardial dysfunction because you've now got a heart that's on shaky ground a lot of the time. You want to make sure that you prevent that systemic response to reperfusion, and we're understanding more and more about the physiology of that kind of response as time goes on. And you want to manage the issues related to the arrest. So, did they have a STEMI? Have they got a massive pulmonary embolus? Have they got something that we can do something about? So what do we need to do? Well, I think we really need to resuscitate the right people, and everybody waxes lyrical about the poor outcomes from in-hospital cardiac arrest, but it is driven largely by selection bias. Okay, we're picking the wrong people, and so our denominator is way, way greater than it actually needs to be. We need to provide effective resuscitation, and one of the things that I think is really evident is that if clinicians believe that a patient has a poor prognosis, it becomes a self-fulfilling prophecy. Okay, they don't get aggressive CPR, they don't get aggressive post-resuscitation care, they don't get the level of, I guess, aggression. If you're going to do CPR on somebody, it's either all in or it's not. Okay, there's no middle ground. And we need to stop this token CPR. And for people who think that doesn't happen, I had a personal experience late last year where my mother-in-law was in ICU. And I raised the issue with cardiogenic shock, and I raised the issue with the intensivist about, you know, if she was to have a cardiac arrest, what would you do? And so as a family, we decided that she shouldn't have CPR, even though she was in ICU and being very aggressively managed. And I had a really interesting conversation with the nurse manager of that unit who said, oh, we wondered where that NFR order came from. And I said, well, it's not an NFR order, it's actually a not for CPR order. I want you to do everything else you possibly can. And she said, oh, normally we just do a few minutes of CPR and then we'd call it off. And I'm like, no, that's not okay. So we need to stop that. And I think, again, as nurses, who are often primarily the responders and the person or people who will commence CPR, if those conversations are happening in the unit, we've got a duty of care to say, actually, no, that's not okay. The other thing I think we need is we need data to evaluate our performance. So we need a national in-hospital cardiac arrest registry, aka the out-of-hospital cardiac arrest registry, and AUSROC have just been successful in getting every state and territory in Australia on board to contribute to an out-of-hospital cardiac arrest registry. So we will have national data, and I think, is New Zealand involved in that as well? No. So that's been a massive achievement. We don't have anything like that in the in-hospital space in this country. The other thing that we don't do well, I don't think, is we don't use our data. How many of you work in hospitals where you routinely download your AED data and analyse resuscitation performance? Yep, so 1, 2, 3 people, yep. And look, we're not resourced to do that very well, so I get why that doesn't happen, but I think if we're going to really be serious about evidence-based resuscitation, we need to look at our data and make sure that, you know, our dose is okay and that our resuscitation performance is good. So that's it in a nutshell from me, and I'm happy to answer any questions or take any comments. And I'm on time. Wow. Yep. So I guess, you know, there are CPR feedback devices. So there's, you know, CPR Easy, QCPR, and so we always focus on, you know, rate, depth, not over-ventilating, interruptions to compressions. I did the worksheet for ILCOR on CPR feedback during real-time cardiac arrest, and there was actually no evidence to show that it improved performance. However, there's pretty good evidence that in training, the real-time feedback does improve performance, and there's pretty good evidence that use of debriefing post-cardiac arrest improves performance. So we haven't quite sorted out the feedback and how we should best use it. We have an idea, but I don't think we're quite there yet. It's interesting, the Global Alliance on Resuscitation, so they focus on pre-hospital cardiac arrest environment. They're now viewing a death from a VF arrest as a sentinel event. So there are ambulance services around the world now doing root cause analyses on every death from VF because they see that as a preventable death. So there's a lot of stuff happening in that space. It's really interesting, but that's great, the way that you're using your data. It's phenomenal.